Good afternoon, and thank you for attending the BCAL Diagnostics Breast Cancer Awareness Education Session. I am Jayne Shaw, and I'm one of the founders and executive chair of BCAL Diagnostics. And I'm very excited to be hosting the event today. BCAL Diagnostics was formed in 2010 with the purpose of developing a blood test to detect breast cancer for all women everywhere. Our science has advanced and has been developed in the USA and also Australia. We listed the company on the ASX in July this year with the purpose of capital raising to continue the science and product development. Ultimately, this is another key milestone in getting the test to market as soon as practical. Today, we've been fortunate to attract some senior leading clinicians who are innovative leaders in the delivery of breast cancer care, from screening diagnostics to breast surgery to individualised treatment of chemotherapy. The event today will run for an hour in total and is being chaired by Professor Sanjay Warrier. We will have 3 10-minute presentations from Professor Mary Rickard, Associate Professor Cindy Mak, and Associate Professor Gillian Lamoury. At the end of each of these 10-minute presentations, there will be an opportunity for questions and answers. So if anyone has a question, please type it in using the Q&A icon within the Zoom app. Thank you very much again for joining us today. And I'd now like to formally introduce Professor Sanjay Warrier, a leading breast cancer surgeon at Chris O'Brien Lifehouse, prior president of Breast Surgery ANZ, the peak body for breast surgeons in Australia and New Zealand, current chairman of training in Australia, and head of research for the breast department at Chris O'Brien Lifehouse. Thank you, Sanjay.
Thanks very much, Jayne. It's a pleasure to be here and to be able to chair this meeting today. And the first thing that comes to mind is why we're all here today. And the reason we're all here today is because breast cancer is a very common disease. It impacts through a lifetime, one in 7 females. And when we think about that as a female, that's often the nucleus of the family. That could be your mother, your sister, the wife, an auntie, and ultimately, it ends up impacting everybody. I have to say personally, as a surgeon and often GP and then other clinicians, we're often at the coalface of management. And what that means is we're seeing the patients when they're most anxious. And also when we see them, they're anxious, we also see their fear. But at the same time, we see their hope. And the hope is that we can provide them with the best possible care moving forward. And with that, I think we have a responsibility to make sure that we improve their care moving forward. When we look at breast cancer through just historically, it's changed through the eras, and it's gone from a time when we were in the pre-Gallen era and we really didn't know a lot about treatment. Then there was a period which we call a pessimistic period, where we actually realised it was a systemic disease, which means across the whole body, but we didn't really know our treatments. We then moved to a Holstedian era, which was the opportunistic era, where we actually thought the bigger the operation, the better the outcome. And I'd like to think we're now in a realistic era where we understand that the disease is not about just surgery. It's more than that. It's multidisciplinary. And ultimately, everything goes together. All the treatments go together to improve our outcomes. So when we talk about multidisciplinary treatment, it's a big team. It's not one person. It involves a surgeon, but it also involves many others, including our radiation oncologists, medical oncologists, our physiotherapists, our breast care nurses, our people that are running the multidisciplinary meetings, our psychologists, and that's just to name a few of the team. But at the centre of the team is the patient. Ultimately, it's about patient-centred care. And why we're here today is to basically make sure that we're providing a message about the innovations relating to cares across breast cancer. And I have the pleasure today to introduce three speakers who are leaders in their fields. And that's Professor Mary Rickard, Associate Professor Cindy Mak, and Associate Professor Gillian Lamoury. So with this, I'd like to start by introducing Mary Rickard. So Dr. Rickard trained as a radiologist and practiced as a staff specialist at Westmead Hospital from 1981 to 1985, and in private practice from 1985 to 1987. In 1987, she was appointed to establish a Sydney-based pilot mammography screening project. This project became a screening and assessment service within Breast Screen New South Wales. She has taken a keen interest in breast imaging techniques and interpretation, and in new technologies and professional training. She was the state's radiologist for breast screen from 2001 to 2006. From 2006 to 2018, she was the chief radiologist for Sydney Breast Clinic, a private clinic for diagnosis of symptomatic breast disease and screening of women at increased risk. She continues to work as a consultant radiologist at Breast Screen New South Wales and Sydney Breast Clinic. She holds a position of Adjunct Professor at Sydney University, and she's been actively involved with the College of Radiologists and with the National Breast and Ovarian Cancer Centre, NBOCC, the International Breast Ultrasound School, IBUS, and the Australian Society for Breast Disease, known as ASBD. In 2002, she received a Member of the Order of Australia Award in the Australian Honours List for service to medicine through the integration of population-based screening for early detection of breast cancer, and also the development of education programs for health professionals. In October 2015, she was elected a life membership to the Royal Australian and New Zealand College of Radiologists in recognition for her outstanding contributions to the college and the profession. It's our pleasure to introduce Mary. Thanks, Mary.
Thank you, Sanjay. It's a pleasure to be here presenting on early detection in breast cancer. So, as you've heard Sanjay mention, early detection or breast cancer is a very common disease. I'll just make sure. Can you see my screen? I'm just making sure that that's okay. Yes? Okay. Early detection is important in breast cancer, just like it is in a number of cancers or other diseases, because earlier you detect a disease, the greater the management options and the likelihood of better outcomes. So while breast cancer occurs in about 1 in 7 women in Australia in their lifetime, we know that not everybody is at equal risk. So here I've listed a number of risk factors for breast cancer in decreasing order. And the commonest one is just being a woman and getting older. Of course, we all know that gene mutations like breast cancer 1 or BRCA1 and 2 are very high risk. And if you have those, you have a high percentage chance of developing the disease in your lifetime. But there are other things as well. For example, high mammographic breast density, which I'll mention in a few minutes, or having a strong family history. That's important. There are other things, but you might be interested in that affluent country of residence is high up the list, right? Breast cancer is actually a disease of affluence rather than a disease of poverty. If you've had breast cancer before, you're at increased risk. If you've actually had a biopsy of something that was a pre-cancerous risk lesion, you're at increased risk. And down the bottom, you can see there are some things that we might be able to do something about, like hormone usage or lifestyle. But they're down the bottom of the list in terms of risk. So if we go back to the top of that list, being female and getting older is the highest risk factor. And you can see the arrows on this figure here, and they point to the age range that Breast Screen works or offers screening. So Breast Screen Australia is actually a national program. It's been here since 1990. It's government funded, free, mammography only screening. So mammography is offered every 2 years to women aged 50 to 74 used to be 69, but the target age group has been broadened. It aims to find an early breast cancer before a woman or her doctor can feel it. And the reason is that mammography has actually been proven to be effective in reducing breast cancer mortality. In fact, it's the only test we have that's been proven to be effective in reducing breast cancer mortality. So the question might be, have the Australian results been good? And they have been. And if we use size of breast cancer as a mortality predictor, we can see that about 60% of the breast cancers that are diagnosed in the screening program are small, that is less than 15 millimetres in size. And that's compared with, say, 30% of those cancers that are diagnosed outside of breast screen. On this figure, the bottom line is the number of cancers or the incidence of cancers, breast cancer in Australia. And you can see it's been going up quite significantly over recent decades. The pink is actually the rate of death. And the rate of death hasn't been going up as greatly as the number of cases. So mortality has in fact reduced in Australia by about 30% since breast screen started in 1990. And our 5-year survival now is up to 91%. The survival gains that we've had over these decades, we would attribute to both early detection and better treatment. Just out of interest, the effects of COVID in Australia, well, we closed for 1 month in 2020, and we don't have statistics out for 2021. But in last year, there were 145,000 fewer breast screen mammograms done in the first 6 months of the year. So the service was closed for a year, but lots of women didn't come before or after that closure. And that's compared to 2 years. Those numbers are compared to 2 years earlier. There were about 12,000 more breast screen mammograms in the following quarter after the closure. So you can see we didn't make up for the shortfall. The modelling on that said that if we actually looked at a 12-month course, we would have a decrease in cancer diagnosis of about 10% over a year. The number of small cancers would go down from 60% to about 48%, and the 5-year survival would go down from 91.4% to 89.5%. Well, just coming back to the results of breast screen, could they be better? Well, probably. Overall, about 50% of the cancers that occur in women 50 to 74 have been found by breast screen. But this reflects the fact that not all eligible women are attending breast screen, and not all cancers in the women who attend breast screen are found actually at the screening process. So what are the issues? Well, there are a range of reasons for these issues. Women, the test itself, how often we offer it, what's the disease process. So the women actually have quite a range in their attitudes to screening and their individual risks. We offer 2 yearly screening, maybe that's not optimal. The mammography itself has limitations due to density, which I'll touch on in a second. The fact that it's a 2D image of a 3D structure, so things overlap one another or are superimposed. And then there are the challenges of taking a good mammogram and actually interpreting it well. And then there's the disease itself. It's not a single disease, but rather a range of diseases, and it's got different appearances, which are more or less easy to detect. So all of these issues are quite difficult to address. The first one you might be interested to see is that women's attitudes to attendance have been, well, they indicate that it's been a steady state for a long time. We've actually never achieved more than a 56% attendance rate with breast screen for 3 decades since we started. Attendance, there is some attendance outside of breast screen for Medicare rebated high-risk screening and for diagnostic mammography, but it's not very high. And if you just look at this New South Wales map or the map of Sydney, you can see that the red areas are actually the hotspots or where attendance has been higher. The blue is where attendance has been lower compared to the background green, the average attendance. If we look at mammograms, for example, here's an obvious cancer in 2018. And if we look back, we can see that there was a little circle in the area where that cancer now is seen. but we would not have recognised that as a cancer because of the problem that imaging appearances of things that are normal or benign or cancerous, they all overlap. And we can see that that little dot looks very similar to other dots on the mammogram in the early phases. Density is another issue. So we can compare these two mammograms. One is a fatty mammogram, where there's less than 10% of the breast is made up of fibroglandular tissue, compared to the other one where white fibroglandular tissue is making up a large percentage of the breast. And we can see that cancers are difficult to recognise in a dense breast where the white cancer looks very similar to the white tissue, unless it's in a funny place or causing some disturbance. So if we look at the risks of dense breasts, there are two main risks for dense breasts. If we compare the 75% with the 10% breast, then that breast has a 5 times chance of developing breast cancer. And it actually has a 20% nearly, 20 times nearly, beg your pardon, chance of developing what we call an interval cancer in the first 12 months. That means that a woman with a dense breast has almost 20 times the risk of a cancer developing in the 12 months following a normal screening mammogram result. So we have risks attached to dense breasts that are due to the development of cancer itself and the likelihood of us missing it on a mammogram. And then there's the tumour histology. So here we have an example of a difficult histology. About 78% of cancers are invasive cancer, no special type, and they're usually a mass-like sort of cancer. But about 11% are invasive lobular carcinoma, and here we see them on a mammogram as a disturbed architecture. So if we compare these two breasts, we can see that one side has a smooth, harmonious pattern, and the other side has a more disturbed pattern and a little white mass up the top, which is actually a metastatic lymph node or a node that's enlarged with tumour. And the disturbed architecture can be quite difficult to recognise and hard to estimate how extensive it is. So in this particular case, the left breast is fully involved with cancer, but that's hard to see. These particular cancers are hard to recognise when they're small and often present when they've already got metastatic nodes. So these are the screening debates. Should we be offering screening tailored to risk? Should we be doing something different for family history or mammographic breast density? Should we be offering screening on a yearly basis rather than every 2 years? And what about the use of a better mammogram? There's 3D digital breast tomosynthesis, which is a type of mammogram where we slice through the breast, and you can see here a mammogram where we can't see a cancer, which on one of the slices is very obvious because it's the tissue over the top of it has been removed. Well, there are other tools like ultrasound or MRI or contrast-enhanced mammography, and we know that all of these tools or imaging tools will actually increase our cancer detection rate. We'll be able to find small cancers this way, but and they're cancers that we may not have been able to find on mammography. And artificial intelligence is something that's come into practice recently. So this could be used to assist or replace a radiologist. So when we look down here at these slices on the DBT, we can see that in one slice, the artificial intelligence software has actually marked a lesion, and it even actually gives us a percentage chance of malignancy for that lesion. So the question might be, does it really work? Well, in fact, it does work quite well in the studies. This figure shows us that an AI software compared to 100 radiologists actually was better at detecting cancer than 60% of radiologists, but not quite as good as the other 40%. So the dilemma is, I guess, whether your radiologist is in the 40% or the 60%. But there's certainly a role for AI in the future. And in fact, all of these issues, mammography tailored to risk, 3D tomo, additional tools and AI are all being used in the private sector to a greater or lesser extent, but they're not currently being used in breast screen. And why is that? Well, the issue is really around proving that they're effective in further reducing mortality beyond what we've already achieved. And what are the costs? So we don't have very good estimations of the financial costs. So it's very difficult to estimate the cost effectiveness of any of these tools. And that's why they haven't so far been introduced into breast screen. So mammography screening, really, mammography only screening remains the gold standard at the moment. But as you can see, there are issues, and it does raise the question of, is there something other than image that we may be able to introduce as a screening tool? And I guess that's really the background behind why BCAL Diagnostics was initially started. So thank you for your attendance, and I'm happy to answer any questions if you have any, or otherwise leave them till the end. Thank you.
Thanks, Mary. That was a fantastic just breakdown of where we are and where we're going when it comes to screening. And on top of that, there was a nice reference to what we saw with trends relating to COVID. I might just start with, where do you see us? You know, we're now starting to reopen breast screen again. What do you think we'll start to see when it comes to diagnoses with it? We've obviously had a slight delay in screening at the moment because of the COVID outbreak we've had in Sydney.
Well, of course, as we know, breast screen is trying to find cancers at an earlier stage, and we only offer the screening every 2 years, which tells you that it's thought that, you know, a 2-year gap between screening intervals is probably okay. So we're not needing to worry about a delay of a month or a few weeks, but COVID's probably going to have a longer delay effect than that, isn't it? It's probably that we saw that while breast screen was closed for a month, we lost, 10% of screens in that whole year. So, or that whole 6 months. So really the problem is that women are probably reluctant to attend the screening, despite the fact that breast screen's now reopened. There'll be a further delay, and of course, a delay of maybe 3 months or more might impact on the size of the tumour and the spread of the tumour and the risk of, therefore, mortality, making it more difficult for us to treat. I really don't know what the long-term effects of COVID are going to be. We really have to wait and see.
Thanks, Mary. So just to reiterate that it's important, if you have any symptoms, to get them checked. And also, on top of that, if you're due for your screening, please, when the screening opens up, please get it done. With that, I'll move to some of the question and answers. The first question comes from Michael Falstein. What is the increase in incidence due to, and is it graded? Is it because we're just picking them up, more of them? So is it because of greater detection?
No, I think the problem with incidence is that, as I mentioned, breast cancer is a disease of affluence. So all around the world, the incidence of breast cancer has been increasing. And that's true particularly of developing nations. Our better lifestyle, fewer babies, having them later in life, maybe not breastfeeding, having healthier nutrition, bigger babies, a whole lot of factors are leading to the fact that we're getting a greater incidence of cancer. So I don't know that there's any answer to how to stop that growth, but obviously we need to address the early detection. And if we can address the prevention, well, clearly that's a long-term goal that's worthwhile.
Thanks, Mary. So the next question is an anonymous and the question is, does the hot versus cold spots for compliance with screening have a correlation with the demographics of the different parts of Sydney? And could you shed a light on the compliance rates in different cultural groups?
Yes, I guess the anticipated differences are there. Affluent areas, more affluent areas are attending better than non-affluent areas. Ethnic groups are attending in lower numbers than Anglo-Saxon or English-speaking groups. So, I mean, the predictable differences are there. Clearly, it also applies to Aboriginal and Torres Strait Islander attendance is low. However, you'd have to just look at the figures overall. 54% attendance as our maximum over 3 decades is really quite poor. And it tells you that half the women that are eligible in this country, despite 3 decades of education about the values of early detection by mammography, have not attended or have chosen not to attend a free health service. There clearly are issues in women's attitudes to attending for breast screening.
Thanks, Mary. So the next question's from Tricia Scott Brannigan. I've heard that mammograms can cause damage to the breast tissue, which can further effects on the breast. Can you please advise how safe mammograms are?
Well, I don't think there's any evidence that the pressure that's applied to the breast is damaging in any way. That's obviously a concern and a discomfort, and that's maybe one of the reasons that attendance is relatively low, but I don't think we have any evidence that it's damaging in any long-term way. If you have a cancer present, you might worry that that might spread the cancer, for example. Again, I don't think there's any evidence for that, but we do know that, from when the cancer is very tiny, it's actually shedding cells into the blood, and they're spreading around the body from a very early stage, long before mammography can actually detect the cancer. So all the evidence we have is that, in fact, it's non-harmful. Similarly with radiation, the radiation dose is quite low. It's much lower than doing overseas travel, for example, in an aeroplane and getting exposed to radiation that way. So as far as we know, it's not got any harms that are significant in that regard.
Thanks, Mary. So the next question is from Lorraine Behrens. Is the use of different types of breast screening or more regular screening limited by cost? And I think you sort of touched on that.
Yeah, I think the cost benefit is really the big issue. We've now got 91% 5-year survival, so that's pretty good. To show a difference between 91% and what we've already got, to show an improvement on that's going to take a lot of effort, a lot of years to show, because people don't die in year 1. They die year, whatever it might be, 5, 6, 7, 8. Most people now don't die in the first 5 years. So we need a study that's long-term to show an increased benefit. And so most governments only really want to do something that they can prove or have proof is of cost benefit. So I think we have to recognise that it's going to be slow for governments to introduce changes to mammography screening.
And due to time, sorry, I'm getting a bit of feedback. Due to time issues, we probably will take one more question. And looking through, there's a lot of good questions that have been asked. One interesting question is, I'll put two together. Does breast density decrease with age? And is breastfeeding a risk factor?
So firstly, the easy one, breastfeeding isn't, as far as we know, a factor, a risk factor, but, breastfeeding may actually improve your risk of developing breast cancer to a minor extent. Breast density is a much bigger, more complex topic. There's no question that your breast density decreases with age for the majority of women at least. So it's postmenopausally, breast density on average decreases, not for everybody, but generally speaking. And it's a major risk factor that is actually very hard to address. As I say, mammography doesn't work terribly well in dense breasts, and how to decrease breast density is not really known. So I won't make that too complex, but basically it's a big risk factor that we have, which is hard to address because we don't have a way of decreasing it, and we know that it's hard to overcome.
Thanks, Mary. So with that, the other questions, what we'll do is type the answers so that you guys get feedback on them, and I'll ask Mary to be able to do that while we run through the next presentation.
Thank you.
So just moving on. So I'd like to introduce Associate Professor Cindy Mak. Cindy is the head of breast services at Chris O'Brien Lifehouse. She's the current chairman of Breast Surgeon's Oncoplastic Breast Committee and has been a long-standing member of the committee. Cindy has a background of training in Edinburgh with Professor Mike Dixon, one of the leading breast surgeons, and is a senior breast surgeon in the breast community. She delivers quality care, patient-centred care to her patients across Sydney. And she's, fun fact, she is a good piano player. And on top of that, she's now a budding tennis player. So I'd like to welcome Cindy to present. Thanks
Thanks for that, Sanjay. Fun fact, Sanjay is a much better tennis player than I am. Okay. Thank you, BCAL, for inviting me to speak. I'll be talking about some treatment innovations in surgery. To start with, I will say that I am a non-remunerated advisor to BCAL, and I have no other declarations and conflicts. So what I thought I would talk about is this. I'll divide the talk into three. First, we'll be talking about two types of techniques that I use, a medical advance and then a device that we're using in surgery. So the two techniques we'll be talking about are fat grafting and perforated flaps. They've been around for a while, but they aren't all that widely used at the moment. So let's just talk about fat grafting first. So this sounds like this magic thing that we do, where we take fat from your tummy or your thighs or some other part of your body, and we transfer it to the breast. It helps to improve divots, filling out defects. If you've got an implant after a mastectomy, we can increase your thickness of the skin over the implant. And it can also improve pain because it brings in a whole bunch of growth factors and new blood supply, and that's been shown to help with pain. People do use it to augment breasts without implants. I'm not a cosmetic or plastic surgeon, so I don't do that. Throughout this talk, I will have some images of intraoperative photos, and if you're sensitive to that, please look away and I will tell you when you can look back again. So look away now. So how we do this is we suck out fat from either your belly or your thighs. Those are the two most likely places because they tend to be the places with the most fat. We liposuck it out just as we would any other liposuction procedure, except the goal here is not to contour you and make you thin. The goal here is to obtain fat in order to re-inject it. You can look back again if you want. So what we use is a liposuction machine like the one on the right of the screen here. This is a basic liposucker. We would love to obtain something more fancy, something called a micro air sucker, which helps us to also contour the abdomen and thigh better. There's a liposuction device connected to tubing, and then after we harvest the fat, we then prepare it. And you can do it in different ways. You can spin it like the centrifuge on the bottom left, or you can just sit it in the rack and let it all separate out. You could even use a purpose-made device. This one's called Revolve, where you spin it, you wash the fat out, and then it kind of separates it all out for you. Okay, look away again, sensitive people. This is us re-injecting fat after a reconstruction. And what we do is we use a little needle and we just put it in layers back in again. You can look back again. What I tell people is this: it's a procedure that often requires multiple operations, often 2 to 3 to get your best result, okay? You can't put the fat in all in one big glob. So I always say it is not a cream puff. You gotta treat it like baklava or something similar, you know, phyllo pastry. It has to be done in layers because the little globules of fat that you put in have to get the blood supply from the surrounding tissue, and if we put it in as a big cream puff, you won't get that. This is what the fat looks like. So the yellow bit on the top is the good stuff that we inject, and the red stuff on the bottom is all the local anesthetic and blood that we then expel. When I first started fat grafting, these are some pictures of implants that I was attempting grafting into. On the left, you see these big, large globules of my first attempt at fat grafting, and that looks pretty awful. That's what we don't want because it's hard to revascularize fat like that. On the right side are nice, smooth little slivers, and that is injection by Mike Dixon, my mentor, who came out for to show us how to do it. And it's beautiful, so nicely done. So that's what I'm hoping that I do nowadays. So the results of fat grafting are really quite subtle, okay? So you can't expect a magic thing that happens instantly. Often it takes a couple of procedures, and they just are generally subtle results, but our patients appreciate them. So this woman on the right side had a lumpectomy, and she had a little bit of a divot after her radiotherapy, and we used a bit of fat to plump it out and reduce the other side. This woman's had bilateral, that means 2 sides implant reconstruction. And on the left side, she still had a little bit of a divot. So we use a bit of fat to plump it out. So as you can see, they're nice for our patients, but they're not huge, huge differences. And now we'll talk about perforated flaps. This is a technique we use where we use underboob or side boob at the back, and we take that tissue to spin it around and put it in a hole that's been generated as a result of us removing the cancer. And we find the blood vessels that supply the area of tissue that we're going to move by using a handheld Doppler, which is this little gray device that I've got in my hand. It makes a little noise and tells you where the vessels are. Please look away, anyone who's sensitive. This is a picture of when we have taken out the cancer. You can see quite a large cavity in this lady. The little yellow arrows mark where I have put some staples to remind myself where the blood vessels are so I don't accidentally interrupt them as I'm mobilizing that tissue to move it into the cavity. You can look back again, anyone who's looked away. So here are some before and after photos of the same lady that we showed you. She had her right side, so that's the breast on your left side, surgery. You can see that is actually quite a subtle difference. You can hardly appreciate that she's had anything done despite having had quite a large chunk of tissue taken out. And that's what the scar looks like from the side. So it's a really lovely procedure. We're increasingly using that a lot more for women for whom it works in. And don't forget, because it's under your breast or the side of your breast, you can't move that tissue to the cleavage area. So this area still is problematic for us when we're taking out large areas. Now let's talk about a lovely little medical advance called gene expression profiling. It's actually been around in Australia for a long while. This is analysis of genes taken from the tissue that we've taken out at the time of the surgery to determine whether or not a patient would require further treatment like chemotherapy. And there is one for radiotherapy, which I'm sure Professor Lamoury will be talking about. The types of brand names that you'll see are things like the ones I've listed. What it does, this is a slide from the Oncotype DX test. What it tells you is that not everybody needs chemotherapy. So there's a group of patients that we're just not sure what the benefit's going to be. And you can use this test to work out whether or not they would benefit from chemo. So you can see even in the postmenopausal group, the group over 50 years, with actually who have had a positive lymph node, whom you would assume would therefore need chemotherapy, there's a whole bunch of them who don't actually require it. And then there's even younger women who don't require it as well. The problem with this test and all the other tests like it is that they cost money, somewhere between $3,000 to $5,500. And unfortunately, there is no rebate in Australia for it. So you have to pay for it. We have attempted to obtain a rebate. We've been unsuccessful 6 times, even though the government recognizes its cost effectiveness and the fact that the UK and the USA use it regularly. And the UK can use something that tells you it must be cost effective because the NHS is a little bit cash strapped. So the problem is that the government is telling us that they want us to run a randomized trial. Now, these trials have all been run already, so it's kind of not ethical to rerun them again in Australia. So unless they change their policy on that, it might be really difficult for us to get these reimbursed. Okay, and finally, I'm going to talk about a cute little device called Scout. So sometimes we have a cancer that we can't feel. We shrink down as a result of chemotherapy, so it becomes impalpable after the chemo. And this is a device that allows us to find it easily, and it allows us to split the process of finding the cancer from the day of the surgery, and it minimizes the number of procedures required by a patient. Normally, what we would do is use something called a hook wire localization. So this is a little wee wire placed on the day of the surgery into the cancer area. It is about $50. Most radiologists will be able to do it easily, but it has some disadvantages. The wire goes in under local anesthetic. If the anesthetic wears off while you're waiting for your surgery, it's painful. Plus, you can't really move around, and you have to keep your arm really quiet because the wire can move and then it's no longer marking the right spot. You can transect the wire during surgery, you can move it during the surgery, and sometimes the radiologists place it so far away from where you want to make your cut that you have to tunnel a long way to get to that wire. And then importantly, it has to be done very close to the surgical timing. So that causes inefficiency because you might want to operate in the morning, but you can't because you've got to wait for your wire to be placed first. So remember that lady who had the perforated flap? You see the little red arrows? That's where the wire is that's sticking out of it that you may have missed before. So this little technique called SCOUT uses a radar reflector that gets placed at any point in time prior to the surgery. So if the patient's having chemo first, you could even place it at the time. You'd normally put a clip in to mark the cancer before chemotherapy starts, and it'll be there and stay there and be detectable at the end of chemotherapy. You then use a little antenna to find the spot that you want and makes a sound that the console picks up. This is my hand. The reflector is about the size of a grain of rice. And there's lots of data that shows that it improves theater efficiency, which makes sense because it dissociates the localization process from the surgical process. So graphic image warning coming up. This is a video, and I'm going to show you what it sounds like when I'm operating.
So I've pretty much got what I think is the lesion here. I'm just going to double check that I have it within my tissue, within this tissue that I'm inside, and that it's not sitting actually below that, which it isn't.
So that little did sound, that's the noise that it makes. It is so intuitive and simple to use. You can look back again if you like. Chris O'Brien Lifehouse has had the privilege of being the first institution in Australia to trial this machine. We now have the consoles available. The problem is the reflectors. They cost between 600 and 750. And once again, there's no rebate on that. So we have to get our patients to fund it currently, and that sometimes is unattainable for some people. And we're kind of hoping maybe we can get a hardship fund going for some of these patients. I couldn't have had this presentation without the help of our medical student Fatima, our fellow Nesh, and Sanjay himself, because they helped to run that trial for SCOUT. So thanks very much, and I'm happy to take questions now.
Thanks, Cindy. That's a fantastic presentation on a lot of the developments that we're currently doing at Lifehouse. So I'm going to go back to one of the questions that was asked earlier on the question and answers. And what is the most common approach, mastectomy and then treatment, or treatment and then a mastectomy? And the other part of that question was, when would you choose one over the other? And the next part, are double mastectomies encouraged currently?
Okay, so my understanding of this question is whether a mastectomy is most common treatment and why we do it. Yeah. So really the answer is a mastectomy does not confer survival benefit over a lumpectomy and radiotherapy. Okay, people think because you have a bigger operation, it must somehow be better, but it is not. You do a mastectomy if you cannot clear the margins of a cancer adequately without deforming the breast. So in an A-cup breast, you could potentially have to have a mastectomy for a 2-centimeter cancer that you would not in a D-cup breast. So it's really about cancer size relative to breast volume. Double mastectomies are not frequently done unless a patient is very high risk, okay? So if they have a very strong family history or carry a gene mutation, it makes sense, but there's never been any data to show that just because you have a double mastectomy that you will live longer. A lot of women have them because they don't want the anxiety of ongoing surveillance and screening. And having had one cancer, the idea that they might have another again in the other side is really confronting. So they might choose to have a double mastectomy for that reason, but it isn't supposed to make you live longer. And that's important to understand.
And then if we were to just add to that, in terms of when do we choose, Cindy, to do potentially chemotherapy first and then surgery?
Okay. So there are certain types of cancers that lend themselves to having chemotherapy first. The common subtypes are something called triple negative, where the ER, PR, HER2 are all negative. And then there's another one which is called HER2 positive, where there's a receptor called HER2 that's positive. These are all great cancers to do chemotherapy first. If you have a cancer where we're not sure you would even need chemotherapy for it, we would not go down that pathway.
And just to, if we were to move on to the molecular profiling, nice summary that you've done. So if we were to use an example of someone who's hormone positive and grade 2, when would you consider doing, let's say, an oncotype?
Okay, so what Sanjay's referring to, the grade tells you how aggressive the cancer is. He's picked a middle grade. Grade 1 is the least, grade 3 is the most aggressive, a grade 2 is somewhere in the middle. And he's talking about hormone receptor positive cancer, which means you have the option of using hormone blocking tablets to treat it. Okay, so this is the good group where you're like, not really sure if they're going to need chemo, particularly if their lymph nodes are negative. And that's kind of a good group to consider using the oncotype or gene expression profiling in. And it would depend on also the size of the tumor, the fitness of the patient. So for example, if you have a 90-year-old woman with that cancer, I mean, the likelihood is you're not going to give her chemo. So you're not going to do that test because it's just a waste of $5,000.
And then just coming back, Cindy, to the majority of our cancers, just to summarize, majority of our cancers, we're doing simple wide local excisions. And you've demonstrated rotational flap as one option. What are the other techniques we use for larger tumours outside of shrinking it with chemo?
Oh, there's all these different lovely techniques that you can use. If you have a breast that's big enough for a breast reduction, we might do that, because the goal is to keep a good breast shape, even if you have a smaller breast. And if you have enough tissue to do that and the tumor's in the right area, we could do that. And we do our best to try and hide our scars using scars that go underneath the breast or around the nipple or hidden up in the armpit area. We can use fat grafting to fill out defects if you've had a lumpectomy that's left you with a defect. So you've got a few options still, apart from just your standard wide local.
Thanks very much, Cindy. And any more questions relating to the surgery, if you could place it on the question and answer tab, and
I'll try to get to them, yeah.
Yeah, thanks, guys.
Thank you.
Thanks, Cindy. So with that, we'll move on to Associate Professor Gillian Lamoury. So Gillian is a specialist radiation oncologist at Royal North Shore Hospital and a VMO at the Mater Hospital with a subspecialty interest in the treatment of breast cancer. She's the recent chair of the Breast Cancer Advisory Group, in brackets Cancer Australia 2018 to 2020, and was in the inaugural chair of the Big FRO and the Breast Interest Group, Faculty of Radiation Oncology, which is what it means. She's also a member of the Strategic Advisory Group for Breast Cancer Network Australia, which is known as BCNA. And Gillian is an associate professor at the University of Sydney, and she's passionate about patient-centred care. And her philanthropic interests and passion are there for equitable access to high-quality care for everybody, essentially. And with that, she's accepted a position on the board of Genesis Care Foundation in 2020. Gillian, many thanks for presenting. I'd like to hand it over to Gillian now.
Thank you, Sanjay, and thank you, Jayne and the BCAL team for this opportunity. I have the privilege of working in a very high energy field. Not only do I gain a whole degree of perspective and inspiration from my patients every day, but I sit around a multidisciplinary table with some highly enthusiastic colleagues, some of whom you've heard from today, bringing state-of-the-art care and no fear in pushing the boundaries to get the best possible outcomes for their patients. What I'd like to do, and I'm pretty excited about the topic I've been given, is to go straight to talking about precision medicine and where things are at. So the NHMRC defines precision medicine, also known as stratified or personalized medicine, as a body of knowledge of genetics and a patient's tissue genome, being able to influence decisions about not just treatment when they've been diagnosed with a condition, but about prevention in terms of lifestyle choices, etc. Now, the promise of genomic medicine is to improve the therapeutic ratio by improving that bang for buck and clinical impact and minimizing toxicity. The basis of this is to find that holy grail of an exact, target or a biomarker which can be identified easily, typically in tissue or sometimes in blood, and then match the right drug to it to give the patient a treatment that will truly work for the condition they have. And given we're talking about breast cancer today, this particular slide illustrates what we do currently, which is a one-size-fits-all paradigm. It's the same cocktail, essentially, of chemotherapy, for instance, that might be used to treat somebody who requires that for their breast cancer, which may have impact in a proportion of patients. It may have no impact in some other patients, and in others still, it may have toxic effects. How best to choose then which treatment to give a heterogeneous population of patients, which is what the lower part of this slide shows, and the future and the promise of genome-guided treatment, is the utilization of genomics, proteomics, samples from blood and other tissue to more specifically target and affect a sustained outcome across a non-uniform group of patients to give them all effect rather than no effect or adverse effect. So the million or billion-dollar question, are we there yet? Where are things at in 2021? And hopefully my next few slides will give you a little bit of a taster as to what is not just on the horizon, but here now. This branch of medicine, when you think about it, is actually quite recent. The whole genome sequence was only mapped in humans less than 2 decades ago. And then under the Obama initiative in 2015, the US pledged about $215 million via the NHS to study this branch of science. In Australia, just as Malcolm Turnbull was exiting and Scott Morrison was coming in, there was a $500 million budget for a similar initiative locally. So this is quite new. This one slide, I hope, and I'll talk you through it, will encapsulate what the current state of play is in how we're genomically guiding treatment. Cindy alluded to how we might select a particular assay called the Oncotype and others to select patients more appropriately for chemotherapy benefit or not. And my brief has been, as a radiation oncologist, to discuss that role in radiation treatment selection for patients with early breast cancer. So this is a graph that's very familiar to many of us working in the breast oncology community, and this comes from the early breast cancer trialist group. It is essentially computing the benefit of radiotherapy on a cohort of patients with early breast cancer who have surgery, trying to estimate their absolute benefit. And we know that only 2/3 of patients will benefit from the addition of radiotherapy. 70% in that green zone won't. They will be cured with surgery and hormone therapy or endocrine therapy alone. The problem is, to date, we don't know how to select who falls into which category based on their pathology, their size and grade and receptor status of their tumor. Well, on the right-hand side of this graph, in the green, blue, and pink bars, what is available in phase 1, phase 2, and some in phase 3 trials to better select those patients that can be safely treated without the utilization of radiotherapy, and that should be 2/3 of patients rather. Of the third of patients who will benefit from radiotherapy, we want to be able to work out exactly what dose to be able to give them, and the radiotype and the Arctic scores are something in this area of research that may gain traction. They're currently in phase 1 and 2. And then there's that 10% group in red down the bottom of this graph who, despite the addition of radiotherapy, will still have a recurrence. So clearly that is insufficient treatment currently. And maybe the assays that are listed there, the radiation sensitivity index, the radiotype and Arctic, may benefit these patients in escalating or intensifying treatment. So the genome omission signatures are something that is available on phase 3 clinical trials in Australia and New Zealand. This is a busy slide, but highlighted somewhere down the bottom third there is the expert trial, which many of us have been involved with, and it's about 1/3 recruited so far. It specifically randomizes women with early stage breast cancer, node negative, who would standardly receive radiotherapy over a 3 or 5 week period, perhaps to omit that and avoid the toxicity associated with treatment and the impost, provided they're found to be genomically low risk on an assay called the ProSigna assay, which is similar to the Oncotype that Cindy has mentioned. Now, there was a nice question which segues into this second part of my talk on DCIS by Linda, I think, on the chat a little bit earlier about the overtreatment of DCIS. Thank you, Linda. So DCIS is pre-cancer. It is often the antecedent lesion in cancer in many patients, not all, and there is a surrogate on something that Mary and her colleagues see in breast screen and in radiology, and that is a blush of calcifications or calcium, typically seen on a mammogram, as you can see in this patient's breast. But the defining hallmark of DCIS is that while it has the nuclear features and cellular proliferation of cancers, it yet hasn't got the ability to break through the duct or the basement membrane or to metastasize. So it's in situ or within the duct. But with the adoption and improving rates of screening and other diagnostics, we know that this can be an overdiagnosed condition. Is it overtreated? Well, let's see what the evidence is. Knowing that there is a grade, as with cancer, of DCIS, it could be low, intermediate, or high grade, and the diagram on the left here shows you the spectrum from normal tissue and the continuum to cancer, which doesn't normally or necessarily follow that it's always going to go from a normal cell, low, intermediate, high grade DCIS, and then to cancer. Many patients don't demonstrate that progression along the continuum. It's about selecting which patients do require treatment. Now, Nemet Hassami and Sophia Omling, colleagues on the local scene, just updated, and this was presented in the Breast Surgery Journal only in June of this year, updated data on where things are at with DCIS in Australia and New Zealand over the past decade. And what I've done is just summarize the salient features from this paper. Essentially, not much has changed in terms of treatment over the decade that they'd assessed patients. 14% of all diagnoses are DCIS. There were some 18,000 cases of pure DCIS in the decade as ascertained from the breast quality audit that our surgeons contribute to. 2/3 of these patients had their standard breast-conserving surgery. 1/3 had a mastectomy. Of those patients who needed breast-conserving surgery, the majority, another 2/3 had radiotherapy. So coming back to Linda's point, and a summary point by the authors of this paper, overdiagnosis is a risk in this condition. And there remains a need to inform not just patients, but the community of us clinicians about the opportunities to mitigate and to de-escalate management and to use next generation sequencing and genome profiling, as we have done with cancer, to separate the utility or not of chemotherapy in DCIS as well. Okay, so the two scores that are here and now on the market and available, not necessarily in Australia yet, the Oncotype, the first of these scores, is similar to the one that is used to make chemotherapy decision-making, was first described in 2012, and it is what's called a prognostic assay. And that means it has the power to tell a patient what the chances of their DCIS becoming a problem are likely to be 10 years and down the track are, but not necessarily guide information or provide information about the utility of a treatment such as radiotherapy. So it's not predictive. The next generation assay, the Decision RT score by a company called Prelude DX, is both prognostic and predictive. Not only can it tell a patient what her chance of recurrence of DCIS is at 5, 10 years and beyond, but what the benefit of radiotherapy addition is likely to be. And this test is available now in Australia since the 1st of July this year. So the Oncotype DX, the first generation of these assays, is a panel of 12 genes, 7 of which are cancer genes, and the remainder are reference genes, and it was first described in 2012. The Decision RT assay is similarly looking at approximately 7 cancer-related genes, but it combines clinical data, particularly patient's age and whether the tumor was palpable or mass-forming, or the pre-tumor was mass-forming, the extent of it, and the margin status. Utilizing this information, it's been validated in cohorts in the US and in Sweden and locally at the Royal Melbourne Hospital by our breast surgical colleagues, Professor Bruce Mann and group recently. And it's able to well stratify the low-risk group and the high-risk group at 10 years and is, again, as mentioned, both predictive and prognostic. So what I would like to do next is, with 3 quick case summaries, describe how this particular assay, now available in Australia over the last 2.5 months, can help as an additional tool for decision-making, not just for a patient with DCIS, but for us clinicians. So patient 1 is 74. She's a postmenopausal lady with a screen-detected, low-volume 6 millimeters of non-high-grade DCIS. And standardly, to date, without the addition of this assay, We've used clinico-pathological criteria, and I use, as do many of my colleagues, a nomogram that's available from the Memorial Sloan Kettering online to compute or estimate a patient's risk and benefit from risk of the DCIS recurring and the benefit from radiotherapy. And you can see with Mrs. SR, surgery alone at 5 years, there's an 8% chance her tumor will come back, and at 10 years, it's 12%, and it's offset with the addition of radiotherapy to about just under 50%. This patient decided she was one of the first patients offered this genome assay as she was diagnosed in August of this year. And the Decision RT score is a score between 0 and 10, as is shown here on the right-hand side, with an elevated score being anything above 3. She had a score of 0.8, and this is the prognostic bit. The predictive bit down here tells her that at 10 years, whether she has surgery alone or the addition of radiotherapy, there's really no additional benefit from radiation. It remains at 7% risk of recurrence. Similarly, for invasive cancer, which DCIS can spawn, there is no additional impact for the addition of radiotherapy, which remains at that static 3% risk of recurrence following surgery alone. So Mrs. SR successfully avoided radiotherapy, which without the benefit of this assay would have been standardly recommended as standard of care treatment. The next patient is a bit younger, and she's got high-grade DCIS, and it's approximately 3 centimeters. And she's a patient I actually share with Professor Cindy Mak. The nomogram from the Memorial Sloan Kettering computed much higher risks of recurrence at 5 and 10 years, and the addition of radiotherapy, again, offset that by more than half. We decided to offer her the assay because she was keen, she'd heard about it, she was keen to consider not having radiotherapy if biologically her tumor markers or the assay came back as lower risk. Whilst she's one of the highest risk scores that I've seen today, well, the maximum score of 10 out of 10, she scored 10 on this. She was slightly disappointed that it meant she would have to go ahead with radiotherapy, but what it did do is solidify for her that the pathology we were seeing and that was in fact an aggressive phenotype, and that she was going to benefit from a significant risk of reduction of both pre-cancer and cancer at 10 years from about 50% to less than 20% with the addition of radiotherapy. And how it's changed my management in terms of radiotherapy dosing is I would offer her a little bit more intensive treatment with the boost or the bigger dose with radiation that I give the tumor cavity. And also, this is a patient I'd be much more strongly counseling to consider endocrine therapy for further risk reduction, given that high biological score. Now, our last patient is a younger still patient, but with a very high volume of DCIS, 8 centimeters, intermediate and high grade. And there was no question in our multidisciplinary discussions about her needing radiotherapy. The question did arise, did this patient need a mastectomy, given the size of the DCIS and the fact that she required a couple of re-excisions to clear margins. The Memorial Sloan Kettering nomogram didn't tell us anything we didn't already know clinically. It sounded like she was heading towards radiotherapy. And in fact, she had started the radiotherapy planning process, and then we submitted this tissue as the assay had just hit the local scene, more as a scientific, I guess, additional tool to guide how intensely we would treat FG. This was the biggest surprise in the 100 patients so far that we've put on this assay in Australia, or had this assay offered to, in that her score came back at 1.2. At a low score, at a low biological, I guess, non-aggressive precursor lesion. She had already made up her mind, regardless, to have radiotherapy, but what it did give her comfort is that there was only a marginal 2% benefit from the addition of radiotherapy, with no benefit on her survival or from an invasive disease recurrence perspective. So whilst it reassured her that it was the right thing to not have a mastectomy, what it does for me from a clinician's perspective is to dial down a little bit on the dose of radiation. I don't think for a young patient as her, I would need to now give her a high dose boost. And similarly, if she were intolerant of the endocrine therapy tamoxifen, I'd feel much less uncomfortable about her not going on it or going to a shorter duration of it, given the fact that the biological features on this assay suggest it is non-aggressive. I have no conflicts to declare or financial disclosures, other than to say that I'm a VMO at the Mater Hospital, which is a Genesis Care facility, which is where the Decision RT assay is being offered. Genesis Care has partnered globally with Prelude DX to bring this assay to my clinic and all our clinics in the last couple of months. Thank you.
Thanks, Gillian. That's a fantastic early assessment of basically a new tool for assessing the potential risk of recurrence. And I guess when we look at both what Cindy's presented and what you've presented, it's showing to the audience that we are trying to rationalise how much treatment is appropriate for patients and how can we potentially tailor it depending on the patient. I guess a question that comes to mind would be when we talk about in the medical oncology sphere, we have our sweet spot for who is a patient that really we're not sure without the test. And obviously we've got those that swing both ways. What would be your sort of sweet spot for potentially the group that outside of basic parameters where you consider this would be almost a must?
That's a really interesting question, Sanjay. And in fact, the validation studies for this particular assay included all comers for DCIS. So regardless of age, regardless of grade, and certainly margin status, I guess, was one of the few factors that did play into that. So even high volume, high grade DCIS, this is a very valid assay to be able to separate low biological from non-low biological risk. So it appears that anyone with DCIS can access this if they're considering making a more informed decision. I guess the way I see it is that it's an additional tool in my armamentarium to be able to guide, and then also not just be dichotomous about should this patient have or not have radiotherapy, as my last case, my 40-year-old patient illustrated. She was already going to have it, but it would allow a little bit more nuanced decision-making in terms of how much to treat, how intensely, and then how much to go with endocrine therapy. But to come to your question about, is there a sweet spot where somebody really should have this test, as with the Oncotype for chemotherapy with that intermediate grade group? I guess I'd be offering it to patients with that low and intermediate risk of a DCIS, anyone with non-high grade, but with a reasonable volume, who would standardly be looking at radiotherapy. Those patients who are less than a centimetre of non-mass forming low-grade DCIS and postmenopausal. As clinicians, we can still offer enough information based on the Memorial Sloan Kettering nomogram to allow that decision-making. But beyond that non-low-grade 1 centimetre or less cohort, anyone who's beyond that intermediate to high grade is possibly looking at radiotherapy regardless. And they're the cohort, I think, where this test may really gain traction to be able to more succinctly separate benefits from treatment or not, and really reduce that impact of overtreatment.
Thanks, Gillian. And just to clarify to the audience, when we're talking about the nomogram, it's essentially a risk calculator. So we put in certain factors into the computer, and it will spit out the likelihood of the percentage of recurrence, both just with surgery or with adding other treatments such as radiation and hormone treatment. So with that, I'd like to thank the 3 speakers for fantastic presentations. I hope everybody's had a fantastic educational session, and I'll pass the mic over to Jayne again.
Thank you, Sanjay. And on behalf of BCAL and the team and all the attendees today, I want to thank you and all the speakers for the presentations and the contributions you've made. Basically, we need to acknowledge that each patient journey for women that have breast cancer is unique and individualised to them. So thank you for highlighting the new innovative surgeries. So BCAL continues to develop its blood test for breast cancer. And in order to do that, we need to access patient blood samples. So BCAL has developed clinical study sites at Sydney Breast Clinic, Lifehouse, New South Wales Breast Screen, a new site in Melbourne under the clinical leadership of Dr. Chantal Thornton. And hopefully in January, we'll be partnering with Associate Professor Gillian Lamoury at the Integrated Cancer Centre Hub on the North Shore. So for further information on these clinical trial sites and becoming part of the BCAL community, please visit our website and register your interest, and we'll be in touch with you. In terms of social responsibility, BCAL takes it very seriously, and we support the breast cancer community by supporting the Chris O'Brien Lifehouse Breast Cancer Department. So any funds raised go directly to Lifehouse, and BCAL are also supporting the McGrath Foundation in sponsoring a McGrath Foundation nurse in areas of need. So I'm sorry we've run out of time. I really apologise for that. We would like to just state that if this presentation today has alerted to any personal concerns about your own personal health, can you please see your general practitioner and talk to them about it. But thank you very much for your time, your attendance. A big thank you to the presenters today, and look forward to being in touch soon. So thank you and have a great afternoon.